Um, it is my pleasure to be here. This is my first time attending this conference. From what I've seen and heard so far, I think this is a really wonderful conference. And I feel privileged and honored, to present some of the exciting things that we are doing in the state of New Jersey. We are going to take a tag team approach to this presentation. So on my left-hand side is the middle wrestler, Mr. Adams. So when he pins you down, you get the point. And then on the other left-hand side is Dr. MerriBeth Adams. So we are going to be, it's going to be a tag team in presenting this. If you look at your package, you can see that it was actually designed as a medication-assisted treatment initiative. And because this is Keep It Real Conference, I'm going to tell you exactly how it changed its name. The name was originally Needle Exchange Treatment Initiative with acronym NEDI. At some time politically, we have to change it to Medication Assisted Treatment Initiative. In order not to bore you on the detail, just when we switch Needle Exchange Treatment Initiative and MADI, Medication Assisted Treatment Initiative, they are one and the same thing. So I will, just for information. Secondly, I also want you to look at the population that we are really serving in this project. They are really this enfranchised population, people who are really not in treatment, who has never been in treatment, with the exception of this project. Okay? Good. How did this project started? Back in 2006, there was a law that was passed in New Jersey that is called the Blood-Borne Disease Act. It was signed by Governor Corzine. This law established funding, regional funding, for the Division of Mental Health and Substance Abuse to establish substance abuse program. This Blood-Borne Disease Act also initiated New Jersey as the 50th state to start what we call Needle Exchange Program. So sometimes we call it Needle Exchange Program, sometimes we make it fancy to call it Syringe Exchange Program. So we became basically the last state to enact Syringe Exchange Program. The most important why we are probably here today is the $10 million that was awarded to the Division of Mental Health and Addiction Services to provide substance abuse program for the syringe exchange participants. This is critical. When we were given this funding, my mandate was to design a program so that all the syringe exchange participants can get access to treatment. And when I was researching how other states and the world have designed their syringe exchange program and looking at the research, one thing that kept on coming to me was treatment on demand, treatment on demand, treatment on demand. And I was asking myself, how do I answer this question? How will these people get treatment on demand, looking at our own substance abuse system in the division? So the only way that I could answer that question was get a mobile medication unit that will provide, located in co-location in those 6 cities that we are doing the syringe exchange, so that there would be immediate access to syringe exchange participants. So there was no other way for me to really answer the question of treatment on demand other than to use a mobile medication unit and co-locate it where the syringe exchange program was going to be. So that's how we built 5 medication units. And I have to retract that when they passed that law, the Division of Health and Senior Services was actually given the mandate to do the pilot project. And it was situated in 6 cities. Any person that is familiar with New Jersey will know that we have it in Patterson, we have it in Newark, we have Plainfield, we have Trenton, we have Camden, and we have Atlantic City. Did I cover it all? Okay, good. So we have those 6 sites. So out of those 6 sites, we decided to have on each site a mobile unit that is outfitted to provide comprehensive substance abuse treatment for all the syringe exchange participants. Okay, and out of those 6 sites, there was one site in Newark where the politics did not allow us to put a mobile unit, but we did have a brick and mortar methadone treatment program that also have access to for syringe exchange participants. I'm actually glad that one of the agencies, who is also a speaker, is here, listening to me and making sure that I'm really saying the right thing. Okay. So if you look at the, your PowerPoint, you will see that we have learned, from other states. Any mistakes that were made in other states in terms of the syringe exchange program, so we learned. So why did I choose the mobile medication unit? I think it is still a very good and exciting, innovative strategy that lets us to deliver treatment directly where the patients are. As we are talking about all the new healthcare reforms and things, the way we deliver service, I really want you to start thinking about how do we really deliver service, to the patients that we are serving. We also talked very much about how do we make substance abuse and behavioral health in terms of nationally to make sure that substance abuse is not just a behavior, but we put it in the public health paradigm. So that's how we designed the mobile medication unit to be a treatment on wheels, basically. Why the mobile medication? According to syringe exchange best practice, recommendations for syringe exchange programs should allow for immediate placement in treatment, treatment slots available on demand, referral to substance abuse treatment in accordance with client's level of care, outreach services. This is so critical, and I'm going to talk a little bit about outreach services when I get to that, to see that without the outreach services, some of the outcomes that we are going to be talking about later on wouldn't even happen without you all. So that we will talk about it. Okay. One thing that was also exciting about this project is, we decided to have methadone and Suboxone in this project. And I believe thus far we are the only state that is actually providing methadone and Suboxone in treatment in the mobile unit for all the syringe exchange participants. Okay, here is what the mobile unit looks like. Most of you that are in this area at least remember Carol Butler. Okay, I call her the queen of the mobile unit because she actually started the first mobile methadone treatment program in the country. And I consulted with her all throughout the time that I was developing this project. Another person that I will actually give also credit was Dr. Bruce out of Yale University, who was also doing a mobile Suboxone only out of his SAMHSA grant. So I visited those programs, but because of the methadone part of it, I have to design a whole total program that will accommodate both methadone and Suboxone. So that's how we also looked at the mobile unit. So this is what our mobile unit is, looks like, and there are five of them, and they are all outfitted. Okay, if you recognize this patient, This handsome patient is waiting in the waiting area of the. Okay. And this patient also is talking to a doctor that actually provides, Suboxone. So I'm really, discussing whether Suboxone is good for me or Methadone. So you can see how he's looking at me right there. What are you talking about? Okay. So on the mobile unit, as a matter of fact, this is really a mobile unit. The Methadone and Suboxone is stored, with a federally certified, DEA certified safe that the nursing, the registered nurse there will dispense the medication. Okay. So when you come into that mobile unit, it's like a unit where patients can get treatment. As a matter of fact, the front part of the mobile unit, you can also close it to do HIV and other healthcare services. It's really, really well thought out by our team. Okay. Right now, I'm going to switch over to Mr. Bucon, who is my coordinator, to talk about who are these patients that are eligible to participate in this project. Mr. Adams?
Thank you, Dr. Iheoma. One thing that I just wanted to mention, this project that Dr. Iheoma said, there are six sites. 5 sites have the mobile unit. Each of these sites has 200 clients, capacity for 200 clients. So we do have 150 methadone clients and 50 Suboxone clients. So 200 clients are served at each of the 6 facilities on an average day. And that means that there's 1,200 more individuals that are getting substance abuse treatment with this initiative, through this initiative. One thing that when an individual walks into one of our programs, of course, we have to look at the eligibility criteria. As with any initiative, any program throughout any state, you do need to develop criteria for what type of individuals we're going to serve. In order to serve this population, we looked at income eligibility, program eligibility, and clinical eligibility. Basically, program eligibility and clinical eligibility are kind of intertwined, and to be eligible for this initiative, we did require that each individual be a resident of the state of New Jersey. They had to have a history of injectable drug use. When we first created the eligibility, we did say intravenous drug use, but we did notice that there were several clients from the syringe access programs that were not injecting intravenously, so we did change that requirement to injectable drug use. They also must test positive for opiates or have a 1-year history of opioid dependence documented. Several of our individuals that come into our program may be from the jail system, and when they get out, they've been taken off methadone or Suboxone. So we do say that if they have a 1-year history of opioid dependence documented, they would also be eligible for this program. They also would have to provide proof of identification, and that's in order to prevent any dual enrollment in medication-assisted treatment, 2 medication-assisted treatment programs at one time. And that's a requirement by the federal government as well, and a state requirement too. They also could not be currently enrolled as a client in any opioid treatment program or be a client under the care of a physician prescribing Suboxone. So again, that prevents dual enrollment. And our last requirement for program eligibility was that they are not previously enrolled as a client in an opioid treatment program within the last 30 days. That's pretty much just to prevent clients from switching initiatives, payer sources for services in our programs. We just didn't want, we didn't want people to be switching people to this program since it is a free initiative, but a payer of last resort as well. We actually do make exceptions, though. If a client was in this MADI program, they drop out, 2 weeks later they want to get back in, we do, override that last eligibility rule. And basically, with our clinical eligibility, as I said, everybody needs to meet qualifications to be an opioid treatment client. Each of our assessments are, a universal assessment, and we do the LOCI and also the ASI, the Addiction Severity Index, to determine that they are appropriate for this level of care. And then income eligibility, basically what happens on the first day of admission or assessment, the individual is assessed for income eligibility. And what we have in our state is called the New Jersey Substance Abuse Monitoring System, which on that system, we have a Division of Addiction Services income eligibility, which is called the DAISY. And in that, the client would have to be at or below 350% of the federal poverty level. So all of our clients do. If they're above that level, they would be put into another program within our state. And then also our Medi-contract agencies do assist the clients in the application and enrollment process for other payers, whether it be one of our Division of Mental Health and Addiction Services slot-funded services, New Jersey Family Care, Workforce New Jersey, or Medicaid. So basically, that's how our individuals get into our medication-assisted treatment initiative. And to discuss further will be Dr. Iheoma. He will discuss the continuum of care model of how the system actually works and how the clients move throughout the system of care. Thank you.
I told you that this is going to be a good tag team. Now, if you look at the diagram up there, this actually came as it was almost like a scratchbook. As we are designing, my thing is, how do we design a treatment of continuum of care so that when the patients come into that mobile unit, if they don't need Suboxone or Methadone, if they need a residential treatment program, if they need an intensive outpatient program, can they be able to get it? I had $10 million to design what I feel that is the state-of-the-art treatment program for any patient that walks into that mobile unit. Okay? If you look at the first circle there, it says Methadone and Suboxone. You see, you have a medical doctor, you have a registered nurse, you have LP, and you have CADC. That particular one is that mobile unit where you saw me in. So if you take this and put 4 wheels in there, that was what I was looking at as we are designing that. So when you come in there, you are going to see the mobile unit. We were thinking about, okay, what really happens? People can walk in, once the mobile unit is on the street, people can walk into that mobile unit. We also looked at the syringe exchange access program that is on the left-hand side of the PowerPoint. So you see that people can come in through syringe exchange program. They can come through the mobile unit. They can also walk in. Now, because of the federal regulation and state regulation for the treatment of opioid dependency, you have to be an opioid treatment program certified by CSAT, DEA, and all the state regulation in order to treat patients. So this project has to be by OTPs. But what I made it clear that it has to have a harm reduction approach to the treatment. In other words, you come in daily today, nobody's going to discharge you because you are not clean. So it was purely very harm reduction approach. Now, when you take that, consider the office-based services where you are going to get your counseling, 12-week of cognitive behavioral therapy, counseling, outreach coordinators, case managers, recovery mentors are situated. This is where their offices are. So they, from the offices, they now coordinate with the mobile unit, the ones in the mobile unit. They are coordinating with the outreach workers that are on the streets recruiting patients. They are coordinating with outreach workers that are coordinating with the syringe exchange participants. Okay, so this is how we designed it. So we know that once you come in here, through all the eligibility criteria and all the assessment criteria, say for instance that a patient needs a detox. this person has been on on opioids. He's been using benzodiazepine, cocaine, and he needs to be detoxed. So what do? The person will go to what we call the enhanced detox right at the left corner below the center box. You see the enhanced detox 37DE. This is not actually in the ASAM criteria. We designed this specifically for this project because our system did not have a system where they can detox patients and still keep them on methadone and Suboxone. Sometimes when an opioid treatment patient goes into a detox, they say, you have to be off of methadone, you have to be off of stuff. So we had to contract with 2 agencies who specialized in detoxing, residential detox, while the patients are still maintained on their methadone or Suboxone. Okay, and once the patient goes in there, say you finish the detox of benzodiazepines and other drugs, and the patient needs to go to a residential treatment program, we send that patient straight to a residential treatment program. Now, I have to tell you that to design this, we had to do a voucher program. In other words, the 6 agencies that have the original contract, they all got 1.2 million to do the regular service. So some of the services that is not part of that 1.2 million is IOP, enhanced detox, and residential treatment program. And Adam approves any patient that needs to go to a residential treatment program. It is identified in that NJSAMS, and Adam approves that patient. The patient seamlessly goes from the residential treatment program, from the enhanced detox to a residential treatment program, or from the mobile unit to a residential treatment program. Okay, so this was really, really an exciting treatment program for us. Out of that $10 million, we've also talked about supportive housing. We've known that, when people have housing, it actually helps them in their recovery. So we also developed what we call an intensive supporting housing team, level A and level B. Level A is, one, if you go to syringe exchange program and you want treatment, you are on level A. If you go to a syringe exchange program, you have substance abuse. Right now, you are not interested in going to substance abuse program, talk about a major harm reduction, you get a housing B. And you have in that housing on the right-hand corner, what we call the ISH team, Intensive Supportive Housing Team, that is made up of substance abuse counselors, outreach workers, employment motivation specialists, where they'll be working with these B clients who are still, they don't want to get to treatment, and we don't want to force them to get into treatment. So they work with them to get them to go into treatment. So this is the network of our MADI project. And out of this MADI project too, because I'll be inviting Dr. Adams, is that we designed a comprehensive data system to actually look at how is this working. Okay, so I really, really want you guys to pay attention, even though that a lot of people do not like data. But this kind of data actually provides the importance of your work. Okay, you are going to see the access to treatment. You are also going to see the clinical profile of the patients that we are talking about. A lot has been talked about co-occurring disorder, the population that we are working. I really want you guys to pay attention as Dr. Adams comes to talk about the research part of the project.
Thank you, Jude. One of our main contract obligations is that the National Center on Addiction and Substance Abuse, which is CASA at Columbia University, and the National Council on Alcoholism and Drug Dependence were contracted actually to look at this research project and evaluate it. So we're evaluating all 6 of the what we call mobile medication unit sites, as well as 2 housing sites. But today I'm really going to keep my comments to the mobile medication unit, just because we're in the midst of ongoing analysis. We're also going to go back and look at all the administrative records of the state of New Jersey for the overall methadone treatment programs and compare this pilot program then with the other match sample. It's really a collaborative partnership. Ourselves, the providers, CASA and DAS, all work together. And I can't thank enough of Bob Baxter and his team up in Trenton, or in Newark, because they bring us the initial clients, and when my staff can't find clients to interview, that program, as well as a lot of the soup kitchens and the ministries, as well as the provider sites, help us locate and continue to talk to the individuals. Now, there are 613 total individuals in the research project. There's over 3,000 in the entire MADI to date. And of that group, they're offered at admission the option to participate in the research project. They talk to their intake counselor or their case manager. And then if interested, one of our research assistants located either in the office space or they go out to the mobile unit, sits with the clients. They agree to be interviewed every 6 months. So that's baseline, 6 months, 12 months, and 18. And they provide us at least 1, if not 2, collateral contacts to help us locate them in case they move, which they very often do, as well as allow us to look at their urine toxicology results. The baseline interview lasted about 90 minutes, and now our interviews are somewhere between 30 and 60 minutes, depending on the actual status of the client when we interview them. These are the sites, and of Camden, Atlantic City, Newark, Patterson, Plainfield, and Trenton. Plainfield and Trenton do not have needle exchange. And that really changed our way of how we're looking at things. Thanks again to our Newark needle exchange, that they also now reference and take clients down to Plainfield. We have 2 housing units, one in Atlantic County, which is Cody, and then the Resource for Human Development in Camden County. And we looked at overall how many of these clients attended needle exchange prior to coming. And as you'll see, the lowest numbers, of course, are Trenton and Plainfield because they did not have those programs. The referral rates were very good from needle exchange, syringe exchange. And then we look at our baseline interview sample as compared to the overall NJSAMS intake in the methadone programs. Suboxone use as compared to methadone in those groups ranged anywhere from 22 to 48%, depending on the site. Our research procedures are that we have all MADI clients were eligible to participate in the research. So we have 3,225 across the 8 sites. That's 6 of your mobile medication units that encompass 542 clients wanting to participate. And then in our housing programs, all 71. So we talk to every single housing client. On baseline, we get consent, we look at the demographics. Our staff also uses the ASI and drug use history, clinical characteristics, use of services. We're looking at motivational ladders. What motivates this client to go want treatment and then go through treatment? On follow-up, we're still monitoring their drug use, clinical symptoms, use of services, experience with their services, and then urine drug screen reports. Our sources of information, we not only have our own interview, but then we do use the database out of the NJSAMS that Jude talked about. And as far as housing goes, we have case managers filing logs on every housing client on their continuum of care every month. Some of the questions we wanted to look at are, what do the clients look like? What are their demographics? What's their geographic base? Are the mobile units servicing these clients in the areas that make it accessible for them? What was the client's experience with this program as well as their programs in the past? And then what are some of the clinical outcomes for this population? And above all, are the clients practicing harm reduction? We're going to compare here the two groups. First of all, the over NJ SAMS population, that's the entire MATI population of 3,225 as compared to just our mobile unit research population of 542. And as past speakers have said this morning, we're looking at an older population. Our mean age is 42, 64% are males, 51% white, 45% Black, Hispanic Latino, 19%, 9% married, homeless, at least 16%, haven't worked in the last 30 days, 82%, and then less than a high school or GED education, 43%. We now compare our MATI research population to that group, and you can see that we're pretty well matched right down the line. We also looked at how much money was spent on drugs in the last 30 days before they came into the program. And on average, it's around $1,500 a month. And they used heroin at least 26 days of the last 30. And we also looked at cocaine of 17%, marijuana of 7%, alcohol of 5%, and then how many of these had ever tried treatment in the past, and we're running about at least 3 treatment cycles prior to this intervention. And 83% of this group were using needles. Again, we look now at the MATI interview sample, and about $1,400 a month as compared to the 15, and then right down the line with 72% of our interview population using needles. When we look at NJ-SAMS versus the interview sample, there's a reason that we need to do that. Over 20% of these MATI clients were interviewed. The samples are similar, which validate both sources of data collection. And then similarities allow us to generalize the findings from the interview sample then to the entire MATI population. Where we did see differences, it was because of non-needle use and then a lack of the needle exchange programs in the area. When we look at treatment history, again, this is baseline. On self-report, 5.7 previous drug treatments at some times in their life. 18% of our research population had no prior treatment whatsoever. We then also looked at the barriers. Why didn't they seek out treatment or stay in treatment? And as others have said this morning, 65% swear to me they can handle their problems on their own. 61% were not ready. And that's where our A and B housing, we try to get them to that point where they'll be more interested in treatment. Stress in their lives, 58% could not afford any. Transportation. One of the biggest things I heard is my dog ate the bus pass. Waiting list was too long. 40% of clients said that just to get into a program and be seen, it was taking them anywhere from 6 months to a year. Of this group, 61% have chronic medical problems, and then only 33% of those were getting actual medications for their medical issues. 25% reported to us either very much or an extreme need just to have medical treatment to function in their daily lives. And then we looked at their co-occurring, their psychiatric. 41% had been diagnosed at some time in their lifetime with a psychiatric disorder, and 12% had had medication in the last 30 days prior to coming into the program. 40% had been prescribed medication at some point in their lives. But within the last 30 days, more than 50% had a depressive symptom, and many of those were to the extreme. 14% of this population were either on probation or parole, and 9% had been in a controlled environment 30 days prior to entering the program. As we said before, 14% are homeless, 19% were in temporary housing, 61% were either couch surfing or had some form of stable housing. Most of them had just about 5 people in their close social network, and then the percent of network that were drug users as well were 20%, and the percent of that support network that were employed at some level was 63%. What does this tell us about the clinical complexity of this population? They have significant co-occurring disorders. Medical problems are prevalent. Psychiatric problems to us are predictive of significant poorer outcomes, and a significant portion overall had no stable housing. What we were surprised about at baseline is that the number of sober and stable in their primary social network. We're going to look a little bit at treatment access. How did they come into the MADI? How were they assessed? And then actually intake. 52% of the population had intake the very first day of contact. So this individual went to the needle exchange got them over to the mobile van, and someone saw them on that day. On average, some subjects waited up to 4.7 days between contact and intake, but some of that was due to not having proper identification. They couldn't prove where they lived or who they were in many cases. Intake and then starting treatment the same day, 68% of this group were actually treated on the first day that they were intaked into the MADI program. Some of them had to wait about 1.5 days, and it was mainly for medical reasons. 88% of the baseline individuals felt it was easier to seek treatment through this MADI pilot program, and 75% said it was easier than their past experiences. 81% of the individuals actually preferred the van to the overall treatment that they had had. I'm going to show you just some very preliminary data that we're starting to assess now of clients assessing the needle exchange program at baseline. 52% of our research interviews were accessing actively at the needle exchange. At 18 months to date, that is now down to 12.5% of this population. Substance use, we looked at heroin, cocaine, benzodiazepine, cannabis, and alcohol. And heroin use with our population was 94% at baseline. That number dropped to 54% at 6 months, and at 12 months, 42%. And our newest data just coming in, we're showing about 33% heroin use at 18 months. Cocaine was 47% at baseline, and that's dropped in the research population to 27% at 18 months. And benzodiazepine has pretty much stayed the same, 2.8, and actually increased a little to 3.7 at 18 months, but we believe this is because of the co-occurring being identified and treated. On marijuana, 29% of our population had high marijuana use, and now that number is down to about 14%. And 53% of our clients had alcohol, and of that number, 20% of those drank to intoxication at baseline, and that number is now down to 33% at 18 months. And there's been no change in any of their smoking habits. When we look at hospitalization, and we'll look at this over time as we're trying to help the state, how is this program helping as far as cost effectiveness and treatment? At baseline, 14% of our clients had to be hospitalized for greater than 24 hours. 37% of those had ER visits, with 3.1% for overdose. That went down over time. We are now at 18 months looking at 9% of our clients being hospitalized for whatever reason for greater than 24 hours. 33% still at ER visits, but overdose is down to less than 1%. We also want to look at harm reduction. Needle use, dirty needles, shared works, and then used works. At baseline, 70% of the research clients use needles actively. At 18 months, that number is now down to 17.9%. Dirty needles was 16% at baseline, and 18 months, it's 3%. And a lot of this is due to the overall counseling that we're seeing, as well as the good work at the needle exchange. Those using shared or used works with others that are doing drugs at the same time were 22% at baseline and 5% at 18 months to date. We also looked at risky behavioral acts because it's all a continuum. Having sex without a condom and without your primary partner, sex with someone who is injecting drugs at the same time, and then sex traded for drugs, money, or gifts. At baseline, 17% of our client base was not using condoms and definitely not having sex with a primary partner. 16% of those individuals were having sex with someone using needles, actively using. And 7% were trading sex for money and drugs. At 18 months to date, we see the non-condom use down to 8%, sex with others using needles down to about 6%, and sex traded for money and drugs down to about 1.7%. Again, all this is very preliminary data. We also engaged in actively looking at the database as well as our interview base on infectious disease testing. Clients were tested for HIV, tuberculosis, Hep B, Hep C, and sexually transmitted diseases. Our biggest boom in reports coming back was the Hep C. On the mean is 31%, but we have one client base in Atlantic County that it's running between 60 and 70% positive on intake. All positive results on this tested group were offered treatment and counseling. So what are our impressions so far? It is really early, but we have low wait times to access the treatment. In the majority of instances, once intake was performed, treatment started the same day. Folks reported significantly easier access than they had with their past experiences. They respond to date to the medication-assisted treatment. So we're not just giving them needles, we're not just giving them Methadone or Suboxone, but it's a continuum of care. And clients do prefer the mobile van going out into their areas where they could not reach the primary programs. At this point, I'll turn it back to Jude for questions.
Okay, we are really done with our presentation. So this is really an innovative program. So we will now welcome questions. And please do ask us questions.
Hi, I'm Bernice Tucker from Baltimore, Women Accepting Responsibility.
Hi, Bernice.
Hi. I just want to say, I want to applaud you. That is a wonderful, wonderful modality. I think you've considered everything that the client would need to be able to access care. We work with women in Baltimore, disenfranchised and marginalized, many of them commercial sex workers. And the thing is, you want to help them into care, but then how are you going to replace their economy, their finances? So then you can offer the housing. I just think it's wonderful. I applaud you.
Thank you.
Good morning or afternoon.
Afternoon.
My name is Marjorie Barnes. I'm a volunteer with the Women Collective in DC. It's a very good program. I applaud you also for your program that you're running also. But the percentage of those who are treated, how many get actually off that medication?
Okay, this question comes out a lot of the time with, especially with the opioid treatment patients. One of the things that we talk about when we start treating opioid dependent patients, statistics over and over and over and over and over again have demonstrated that a lot of the time when the patients stop using medication-assisted treatment program, they go back and spiral back to exactly what they used to do. And I'm also here to tell you that for a long period of time, methadone has been really well tested, despite the fact that people in the community, people have this negative view about methadone, okay? But nobody has any negative view about if you have a high blood pressure and you have to take your medication on a daily basis, or you have diabetes that you have to take your medication on a daily basis. Nobody says anything about you because we have to take this medication the rest of our lives. But once it comes to an IV drug user and methadone, you have to get off of that shit. Did I say that? Oh,
Yes.
Okay. Okay. So, but that's really what that's really. I can't believe that this is being recorded. Okay. But this is really what really happens, for our IV drug users. So we outreach workers and clinical people, we need to continue to advocate for these patients because they do well while on medication. That is just bottom line.
Yeah. And the reason why I asked that question is because I see a lot of those who are on methadone, who are out in area in DC, who are buying other drugs when they're on methadone. So I'm wondering if this is working, because a lot of the homeowners are having so much problem with those who are on methadone in their community. So I'm wondering, is this really working? Maybe it's working in your area, where you are, but I don't really see it here.
I will tell you, substance abuse, there's always a way to really look at outcomes, okay? There are things we look at outcomes. And one of the ways that we look at outcome is, quality of life, okay? I came here today for this program. You really don't know whether I took my methadone before coming. You don't know that. I have a job. I have a family. I'm healthy. I'm doing what I'm supposed to do. That's how we judge. I mean, that's what we have to be looking at outcome. You don't know all the things that I did today. But as far as my job is concerned, I think I have come here to do my job without you knowing whether I took medication before coming here, but it has been effective. So for some of our clients, we really need to look at quality of life. One of the things that I really want to talk that we also introduced, because we never really talked much about, Suboxone. This is actually the first project that is really looking at using Suboxone for our population. And it's still very, very preliminary to start comparing how well the Suboxone patients and methadone patients are doing. That is something that we are still, working on. If we are lucky to be invited back next year, we'll talk about it. Okay.
Hi. Along with you promoting harm reduction and your clients are living productive, are a productive member of society, do you also encourage or strongly recommend that they attend a 12-step program such as NA that'll keep them from going back to using needles so that they can continue on living this healthy, productive lifestyle?
Absolutely. They do not come to the programs to just take methadone and Suboxone. As a matter of fact, the two groups, according to both state and federal guidelines, we have stages of treatment for methadone patients. Several counseling the first 90 days, several counseling the second 90 days. The same thing with for Suboxone patients, we actually mandated 12-week cognitive counseling that is mandatory, for all the patients. So of course they continue to get counseling all throughout the treatment. They do. Yeah.
Good morning. I would like to say thank you for mentioning Ms. Butler. She was my first program director when
Thank
I
you.
entered the field. Question, why do you think the mobile treatment has not been more widespread across the United States?
That is a very, very good question. As a matter of fact, the first time I mentioned mobile medication unit in New Jersey in our division, everybody says like, mobile what? Okay. Actually, the reason is simply the NIMBY issue. Not in my backyard. In as much as we felt very strongly that this is one way of expanding treatment and access, but when we were trying to implement this project, I was very surprised that a lot of people did not want the mobile medication in their units, even in cities. So that's really part of the problem. But I also feel that when we start getting this kind of outcomes that we are getting, especially with the whole healthcare reform, with active, with your outreach, working with collaboration and this kind of outcome, then people will see the effectiveness of the program. Remember, nobody wants the people that we advocate for. That is part of the problem. We don't want these people in our neighborhood. Okay, we can't start a methadone treatment program because we don't want these people in our neighborhood. So that's probably one of the reasons. But secondly, I think more importantly, that the more we start doing research and showing people the number and how well they are doing, I think we will start, turning the clock. Thank you.
I have a question.
Yes.
Hi, my name is Angela. I work for the Women's Collective. I just have a question I want to ask you. How long is a person allowed to take methadone? Because I've been in the field. I'm an outreach worker, and I've been in the field, and people are telling me that they've been on methadone for 20 years, 25 years. I mean, is that the way it's supposed to be for them to continue to be on methadone for that amount of time?
There is no research that have indicated that if you are on methadone for a long period of time, that it will going to be harmful to you. So what happens in treatment programs, every treatment program is individualized. There are certain patients that will go on methadone for a long period of time. They will start talking to their doctor and the counselor, you know what, I think I really want to get off and try. And sometimes some patients have successfully done that, but there are a very small percentage of patients that have done that. But this is one of those things that you work with your doctor and your team to say, okay, let's start tapering you off. Maybe 80 milligrams, we start tapering up. But this is a medical condition that every single patient needs to discuss with the treatment team. Okay, there's one more question now.
Hi, my name is Genoa Rucker. I'm from Sasha Bruce Youth Work. I'm a sexual health and wellness counselor. I don't know much about this, but I want to know, what are the side effects of methadone and Suboxone? And if tested in an employment situation, would somebody lose their job because this is found in their system? Also, just to piggyback off of what everybody else I think is thinking in here, is it possible for someone to gradually get off of the medications that are being provided?
Okay. I will take one question at a time. I am the state methadone authority for the state of New Jersey, and in the country, we all have state methadone authority all throughout the state. There are regulations and issues in terms of whether you are a truck driver, the kind of job that you do. But these are the things that we are working with the federal government, CSAT, in terms of looking at all the research that has been done that patients that are on methadone can't do any job like anybody else. Nothing have been indicated otherwise. Through research, through treatment, through interviews, through anything that I can ever think of, nothing has indicated that when patients are appropriately medicated with a medical doctor on a certified OTP programs, they can do any job that they want to. I've already answered the other question in terms of whether the person needs to be on methadone for life. That is really a treatment issue, just like blood pressure medications. If I'm exercising well, eating right, my my doctor may say you may not need this amount of milligrams. But we need to understand putting substance abuse, opioid treatment in a public health paradigm is the key. It is not sinful. It's not a behavior thing. Addiction is a brain disease. And I also want to tell you one good thing about the Suboxone, without getting technically, it does have an agonist and antagonist part of the medication that when it locks up into your neurotransmitter, it actually blocks any other opioid treatment program coming in. So that's one good thing about this new medication. Patients cannot overdose on it because of the antagonist part of it. But not every patient will do well on Suboxone. Thank you very much.